Thank you for joining the Cancer Survivorship Project ECHO, the kind of new and improved mini-series that's going to be focusing on self-management during COVID-19. And this is the first of a 3-week series. So we will see you this Wednesday, next Wednesday, and the following Wednesday to talk about sort of hot topics and relevant topics that we've been hearing from you, from across the region, and then kind of areas of interest that we've picked up from professional organizations and other peers. So we're very excited that you're participating tonight. And for those of you who have not participated in a Project ECHO before, or for those of you who have participated in one of ours or other ECHOs in the past, this format will be slightly different. We will still cover great information and didactic, but we're not going to spend as much time on our check-in process as we go through the sort of housekeeping for our initiation of our ECHO. And then the cases have been built more into questions within each of the topic areas instead of having sort of a standing set of case presentations that we normally cover at the end. So just wanted to give you a little heads up that this will be slightly different, but the same. And the whole goal, once again, is to continue building our community of practice. All of you across Kansas, Western Missouri, and across the region and across the country, we are very excited to continue to engage on a regular basis through Project ECHO and other tools so that we can build that ongoing community of practice. We also want to make sure that you know that all of our materials for this ECHO and all of the others are available on the Masonic Cancer Alliance website, which you guys can access and have all the materials for that we cover in the toolbox, as well as other topics that we think might be of interest to you. Tonight we have a great cast. I'm Jennifer Klemp. I am the Director of Cancer Survivorship at the University of Kansas Cancer Center and the course director for our Cancer Survivorship series. But we also, with our mini-series, have added Dr. Christian Sinclair as my co-director for the ECHO mini-series. And he is an associate professor of medicine in the, and as well as one of our leaders in oncology palliative care. In addition, we'll have Dr. Alan Greiner, who's a professor of family medicine. He also wears about 5 different hats, but for tonight, we will talk to him from his medical directorship at the Wyandotte County Health Department, how he's really helping to coordinate with the University of Kansas Medical Center and the state health department across the state, the region, and the country to help better prepare us for what's happening and what will happen. And Dr. Shauna Wright, who's the Associate Director for KU Center for Telehealth and Telemedicine. We are lucky to have her. She's a wealth of knowledge. They have a whole grouping of tools that we're excited to share with you guys tonight. And then, of course, all of you are participating. So we want to make sure that you are chiming in, and we will kind of talk you through that like we do on all of our ECHOs. Real quick, we're going to cover our housekeeping and then dive right into the content, which we're all here to talk about tonight. Our continuing education statement. You will be getting credit, both nurses, advanced practice providers, physicians. Social work has been added, and then there's also a certificate of attendance if that is your preference as well. The important part about our disclosures, no one has any disclosures except for myself, which are listed here. And these slides will be also posted on the Masonic Cancer Alliance website, so you will have access to those following the program. There's 3 ways to get your CE. You can text, you can log in, or you can use the app. And sounding very Midsummer Night's Dream, 51NIGH is your code for tonight, 51NIGH. And we will show that again at the end of the session so that if you miss it at the beginning, that's your code to get your credit. We are supported for this effort by a grant and cooperative agreement from the Centers for Disease Control and Prevention. It is a survivorship grant that we work with the Kansas Department of Health and Environment on, and we get additional support from the University of Kansas Cancer Center, as well as the Masonic Cancer Alliance. So this is where we'll modify just a little for tonight, and wanted to just show the organizations participating tonight, and then we'll show kind of all of you. So the important part of the check-in is it helps us build our community. We get to know each other a little better, and hopefully we start to kind of build those relationships by asking questions. And I know many of you followed up with questions following the echoes. Tonight, we're going to let you chime in and say hello in the chat box, which most of you are very prolific with, as well as throughout the evening. If you have any questions or comments, please use the chat box, and we have some of our team members who are on the screen as well, and Trish and Tracy in particular, who will be manning the chat box so that we can include your questions as we go through for our team of subject matter experts. So please say hello. Hope from the Masonic Cancer Alliance has chimed in, so please check in. In addition, for some of you where there may be multiple people at your location, this is even more important because we want to make sure we count everybody who is there, and we can go ahead and add you to the roster to make sure that you get counted as attending for tonight. So please, if you can, keep your screens on. We do like to see you, and that's one way we get to know each other a little better. All right. But all of these organizations listed here, as you can see, there are members from each of these that have registered, and people continue to be checking in tonight, as we can see the number of participants increasing. In addition, we have some from outside our catchment area, so thank you to all of you for chiming in tonight. We will be recording, so just wanted to let you know that, and we hope that by you being on, you are giving your consent to do so. So how do you look a little better? Well, as you can see, many of us have been practicing all of our Zoom skills, right? So we make our little office on our wall in our dining room, or wherever you are sitting. And so make sure that we can hear you, we can see you. So if you do have a question, that's great. We want to hear that. We want to speak clearly. We want to look at the camera. And we don't want to necessarily see the ceiling. So please do try to show us who you are by making sure your camera is at a good level, and that we can see you and hear you. And we're so glad to see many of you on tonight, because I know that's been sort of, it's hard. None of us like to show our cameras all the time, but we do like to see you and get to know you. So thank you for sharing. In addition, we're going to be using polls, and many of you have gotten pretty good at this, but for those of you who haven't used a poll within Zoom before, it's very easy. You're going to see a question, you're going to have some answers, some choices, and then as you answer that, we'll go ahead and post the responses. They are anonymous, so you don't have to worry if it's something that you may not know the correct answer, or you're not sure. Go ahead and answer to the best of your ability, because it is anonymous. So we thought we would start by asking you a poll question, and you can obviously answer via the poll, or if there's additional information you want to put in the chat box, please feel free to do that as well. And do you feel adequately informed about COVID-19 and the impact on cancer care delivery in your organization? And so Tracy's going to pop up that poll, and you can go ahead and answer. Or maybe I'm going to pop it up. There we go. Sorry about that. Is the poll up, or am I? Nope. I hit launch poll. Tracy, are you launching, or I tried to launch it too? Maybe we're both launching.
It says that everyone's viewing the questions.
Okay. Shauna, are you seeing the question?
No, I'm not, but if I'm a co-host, it might not pop up for me. So I'm seeing
okay.
the slide, but I'm not seeing the actual poll.
Okay. Maybe Luca is going to give us some expertise, since she is our expert on tonight.
It looks like several people are saying they're not seeing the poll.
Okay.
I know, and I'm not seeing it either, and I actually haven't used this yet, so I don't know.
Oh, there we go.
There we go. It's up now.
Woohoo! There we go. It just wasn't fully loaded. There you go. So yeah, we are big pollers normally, so we will do that, and we're going to go ahead and end the poll. And there we go. So can you guys all see the responses? All right. So, it's a little bit of a split. And I think the interesting part is as we talk tonight and we really dive into some of this content, the important part of this response really is that this is fluid, right? There's a lot of things happening. And so I think the important part is by continuing to have dialogues and all the resources that are really coming down the pipeline, we want to help digest that for you and really bring that together. And I feel like the folks we brought together and also teeing off with Dr. Greiner, we're going to be able to hear about how some of these communications are happening, which I think are really important for you because there's so much information out there, and we want you to get the best pieces that apply to you and to our patient population so that you don't feel sort of overwhelmed and we don't get misinformation. So thank you for responding. All right, so we are going to dive in, and Dr. Greiner, are you available to chime in?
I am.
Great.
I'm ready to go.
Great.
So I'm Alan Greiner. As Dr. Klump mentioned, I'm in the Department of Family Medicine at University of Kansas Med Center in Kansas City, and then also serve as the health officer at the Wyandotte County Health Department. And normally I spend about 4 hours a month working on things at the health department here in Wyandotte County. But for the last 3.5 weeks, I've been here every day, all day, and done a lot of extra stuff. And so my regular job is kind of on the sidelines now. I also do quite a bit of cancer-related research work, some with Dr. Klemp. So Dr. Klemp and I actually have a project called Cancer Survivorship, which I think we'll mention more about here in a minute, where we're trying to help rural primary care practices improve their cancer survivorship care. I've also done a lot of things on promotion of cancer screening among underserved populations, both rural and urban, as well as a variety of other projects really across the state. And I'll talk about some of that. But starting off with COVID. So I don't know that I'm the best infectious disease expert on this topic, but I've certainly had a crash course in the public health approach to this novel coronavirus, COVID-19, that we are grappling with now in our state, and people are grappling with really all over the world now. You can see from the map here on this slide that Johnson County and Wyandotte County, Kansas are having the highest numbers of cases. The last map I saw on per capita cases, I actually think Coffee County might have still been in the lead. They had an outbreak at a nursing facility in Coffee County, but I worry a little bit that here in Wyandotte County, we may overtake that. We also have a rehabilitation facility that's got a major outbreak going on in it here now. The numbers on this are actually a little bit out of date now already. Everything is changing by the hour with this, and I'm sure people are pretty aware of that. We're well over 200 cases in Wyandotte now, and last I heard we had 13 deaths. And so we are seeing, in terms of the Kansas City metropolitan area, for the positive cases we get, the case fatality ratio looks like about a 3% fatality ratio. Now, I think we all know we're under testing, so we don't have a good sort of incidence rate for this condition. And a lot of people feel like that's true really all over the globe. But we definitely, I think, know and began to experience a few weeks ago around here that this is a very serious virus. When people get the virus and when they get significantly ill with it, they have pretty bad problems and complications. And so we know that lots of people end up hypoxic or with low oxygen levels, and we know that lots of people end up in ICUs on ventilators, and I'm sure lots of people have heard all about this in the news. But when you see it firsthand, which we are now, it really is pretty scary and remarkable. And unfortunately, I think many of us in the United States did not heed some of the early warnings coming from international environments and may have been a little complacent based on experience with prior infectious diseases like Ebola and the first SARS virus and the MERS virus. But we're seeing it now. The current data for our health system, University of Kansas Health System main hospital here in Kansas City, as of about noontime today, they had 37 hospitalized patients with COVID-19. They had 9 patients that had tests that they were awaiting results on and had symptoms of it. And then they had 11 of those total folks in ICU beds, and 9 out of 11 of those patients in ICU beds were on ventilators. Our other hospital here in Wyandotte County had 19 positives, 8 pending tests with symptoms, and 10 in ICU beds. One thing that we hope will continue that we have seen the last 4 or 5 days is these numbers at the 2 hospitals in Wyandotte County have stayed relatively stable. So we haven't seen massive spikes or steady increases in the numbers of individuals in the hospital with positive tests and the number of individuals in ICU. So we hope that that is a really good sign that good things are happening based on some of the mitigation measures that have been put into place. We can't promise that, and I think most of us are a little bit nervous about even talking about that so that we don't get ahead of ourselves. But many of you may have seen in the news that we were really worried that what would happen with this virus is the increase in cases would really just keep going up in an exponential fashion, so that you might see 10 patients in the hospital and then 30 and then 80 and then 250, and that's what's happened in some parts of the world and even in some parts of the United States. If you can keep your caseload on a more of a linear path where you're seeing a gradual increase, but it's not spiking straight up, it's more on a straight line, it gives you more time to get more equipment in place and make contingency plans. And so we're hoping that's where we are. You can go to the next slide.
Let's ask real quick, like, if anyone has any questions about that, because I think that's really what you're talking about with kind of keeping the curve down, is that through those measures, that's the goal. And does anyone have any questions for Dr. Greiner so far? Okay.
Yeah, and if people put things in the chat box, Jen, you or somebody can just
we'll read them
off, and I'll feel free to interrupt at any point as we're going along.
Absolutely. And then if you could dive into kind of how are you guys all communicating, and what's that sort of look like as you're kind of having this command center and communication strategy?
Yeah, so we've really never seen a public health emergency like this with an infectious disease in my time as a health officer in Kansas City, Kansas. And I've been the health officer here for 15 years now. So this is a unique time. In the early days of cases in our region, in the Kansas City metro area, which, again, is like three and a half weeks ago or so. Actually, I think tomorrow we'll be at 4 weeks from our first case in Wyandotte. There was a lot of metro-wide coordination here in the Kansas City metro. So there's something called the Core 4 work group that meets on occasion, and it involves the mayors of the major cities in the metro and the county commissioners or county heads from the different counties in the Kansas City metro. So Johnson County, Wyandotte County, Kansas City, Missouri, and Jackson County. And that group worked really tightly together on planning different strategies and discussing how data would be shared. There's something called the Mid-America Regional Council that some of you that work in Kansas City have probably heard about, that's worked on metropolitan transportation issues and sharing, but they get involved in health issues too. They're working really hard to try to coordinate the availability of hospital and healthcare facilities with this. So there's multiple phone calls happening sort of every day on this issue. Some of those are metro-wide, but then there's also others that are state of Kansas focused. In fact, I'm missing one right now that is a group of about 45 county health officers that do the same thing I do here, that's meeting once a week. And I'll talk about this later. We have, Dr. Klimp and I work with a lot of rural providers, and we have a network of rural providers called K-Pepper that some of you all may have heard of previously. A fair number of the physicians that are members of K-Pepper and have helped us out with different research over the years are also county health officers. So it's been interesting to coordinate with those folks on things. We've worked together to submit letters to Dr. Norman, who's here on this slide, and letters to Governor Kelly, and kind of get our voice heard in terms of what we think ought to be happening with stay-at-home or shelter-in-place orders, and what ought to be happening with making decisions about when bars and restaurants ought to close, or when different types of gatherings should be allowed or not allowed. People may have heard in the news that in the past few hours there was some crazy political things happening in Topeka, and the governor's order to suggest that churches should not be having services was rescinded by the Legislative Coordinating Committee over in Topeka between 2 and 3 o'clock, I guess. I don't know what that will mean for this weekend, but we actually have orders in place here in Wyandotte County, and I believe there are many other counties in the state that have orders that will be able to supersede that, because they're stricter orders. And so
that's a good point to bring up. Do the local or the county, who supersedes who? Is it the order that's the most strict, or does the state trump the local? How does that work?
It kind of depends on how the orders are written. But the way the governor's original stay-at-home or shelter-in-place order was written, it actually superseded other shelter-in-place or stay-at-home orders. But if you had additional orders that you had also already put in place, those additional orders could be more restrictive than what the governor put in place. So we have had stricter orders here in Wyandotte, and so has Johnson County all along. And we believe that will help us this weekend. I don't know the case in Sedgwick. I know Topeka and Lawrence also have stricter orders. But a lot of the more rural counties that we work with do not have strict orders. They were kind of relying on the governor's orders. So there could be problems, I think, in some of the rural parts of Kansas.
And are you predicting any disparities in our rural counterparts as they care for COVID-19 patients?
Yeah, unfortunately, I think that's what we're likely to see. We're already seeing that kind of stuff across the United States, in terms of having communities that are more underserved or have higher rates of chronic disease are being more affected by this virus. We've already had 3 church institutions in Wyandotte County that have had COVID-19 clusters within them. The first of those, this says 2, but that was last week. That was last Friday, so we haven't updated that slide.
Sorry, hold on, let me go back. Sorry, I'm good. I went too fast. And that's the amazing part, is that as soon as we make a slide, it's out of date.
Yeah.
So hold on.
Yeah.
There we go. Yep.
Yeah. So we've had 3 church clusters in Wyandotte County. The first of those 3 actually goes all the way back to a gathering on March 12th. That I think we had 16 cases out of. There was another ministers convention between March 16th and 22nd that has ended up with 19 positive cases and a number of hospitalizations out of it. And then there's a third church with a smaller number of cases. All of those clusters had multiple hospitalizations, and you can imagine why. Well, at least in our county, I don't know what it's like with the rest of the state and where all of you live, but our church-going population is older, and in some cases, it's a population that has higher levels of chronic disease. And we are extremely nervous about what could happen over Easter weekend if we had a bunch of churches trying to hold services and have communal meals together and that kind of thing. The same reason we're worried about those populations is why we're extremely worried about cancer survivors, and everybody can imagine that as well. I mean, it's basic common sense. But cancer survivors are a super high risk group when it comes to this virus. It's affecting people that have compromised or even minorly compromised immune systems in a much more significant way, and that's certainly true for cancer survivors. Some more than others, but some may not even know that they've still got something with their cancer, and they would still be at high risk. I mentioned the rehab facility too on that prior slide. That facility was at 15 cases. As of now, that facility is at 56 cases.
Oh, wow.
So so it's just continued to explode at that particular facility. They've had 7 deaths out of that one facility, and they've got 7 people still in the hospital, and a bunch of staff. At last count, 8 staff were infected. So these things where people are in close proximity can blow out of control really, really quickly. And that's where the whole idea of these stay-at-home orders comes from. And I think we all have to be vigilant about this, especially probably in healthcare facilities. And we are going to have some of our cancer patients and some of our other chronic disease patients who just have to be seen and have to get care. And we all just have to be super careful. We do have good studies that show if everyone's super careful with what they're doing and wearing protective equipment, that there's very little spread that happens in a healthcare environment. But it takes diligence. It takes careful attention to washing your hands and extremely careful attention to what you're doing with your hands. All of us, I think, get busy with what we're doing in the healthcare arena, and then it's allergy season and we rub our nose, and that's how you get this virus if somebody doesn't sneeze or cough right on you. So I'm encouraging people to get really good at practicing the act of never touching your face, hands to your mouth, nose, eyes, ears. And if you do wear masks, right, and we have this new guidance suggesting that all individuals who are out in public should wear cloth masks if they can't assure that they'll be 6 feet or greater away from other individuals. I've been trying to emphasize, yeah, that's probably a good idea. It probably protects other people more than it protects you. But you have to think about hand hygiene. Your hands have to be super clean when you put the mask on, and they have to be super clean when you take it off. And if you don't do that, you might actually be exposing yourself to greater risk because of the fact that this virus can sit around. We now know it can sit around on a tabletop or a plastic or metal surface for 2 to 3 days. The reason you're hearing people talk about putting N95 masks in like brown paper bags is because for some reason the virus survives a lot shorter time period on paper or cardboard, sometimes even less than a half a day. So we're hearing a lot about that. This mask thing is controversial, and I'm sure some of you all are getting questions about it. If I've got a cancer patient or a cancer survivor, should they actually go to the point of wearing a more
We have a little bit of that coming up.
mask? Do we have some of that? Okay.
Yeah, we're going to talk a little more about that here in
Yeah.
a few. Which will
I'll
be
give you my opinion. I mean, I know that we've got a shortage, and we're trying to reserve these N95 masks for healthcare professionals. But clearly, the reason healthcare professionals are wearing them is to protect themselves, and we probably have to think about, if we know we have enough to make it through for a while, do we have our cancer patients and cancer survivors wearing these things? All right, let's keep going. I'm taking way too much time, probably.
No, you're doing an excellent job. But all I can tell you is when you were talking about that, I just want to scratch my nose now. So I'm going to try really hard because you're making me want to scratch my nose.
Yeah.
Okay, so if you could talk a little bit about kind of testing, because I think that's where people kind of get a little concerned too. Like, wouldn't it be great if we could do more public health-based testing to see if people had it and have antibodies? How do we test to see if people, are currently, who are symptomatic, are positive? So if you could give us a little bit of background on testing and then how your protocol works here on this screen.
Yep. So testing has been a moving target, and it evolves every day. This is our latest protocol we're using here at the Winnetka County Health Department for testing. But 3 weeks ago, we weren't even able to utilize something like this, because there were some people in the Kansas City Metro that thought we only were going to have enough tests to test hospitalized patients. We started to get a little more test availability from regional reference labs right after that, but the initial tests that were going to those regional reference labs were taking 7 to 10 days for the results to come back, which wasn't very helpful. Now that's begun to change because we have some local smaller labs that have begun testing, and places like University of Kansas Health System Hospital here has started testing internally. So we are going with a fever of 100.0 degrees as a cutoff. And initially we were wanting people to have multiple symptoms, so fever plus cough. We've abandoned that, and we're just now fever. You have to have a fever. We are almost to the point where we're going to move beyond that. If we can get enough swabs and test kits around here so that we can take anyone who has a cough, or certainly anyone who has a cough, sore throat, fatigue, diarrhea, body aches, and has had a contact with somebody who's positive or has traveled somewhere that's a high risk area, we may be testing those kind of people by next week. We don't have reliable antibody testing. I'm sure lots of you have heard about antibody testing. What the FDA did is they created a waiver situation where labs could try to launch antibody testing for this condition, but we got some guidance from our pathology department at University of Kansas yesterday, and none of these things have been validated. Mm-hmm. So you don't want to get in a situation where you're doing anything other than research work with these antibody tests, in my opinion, at this point in time. Now, if we had a lot more tests like they've had in places like South Korea and Germany, we could test a lot more people. I would still probably argue against testing people that are totally asymptomatic, because it's possible that people who are asymptomatic, we test them and they're negative, they get a false sense of security, they go back to work, or they start doing more things around other people, and then 2 days later they start having a cough and they develop fever, and they could have actually been transmitting the virus in the 2 days between the time they had a negative test and they developed the symptoms. And that's just an issue of what's your viral load in your system when you get the test, and how much virus are you shedding from your nose and that kind of thing. So we are not promoting asymptomatic tests. I am kind of disappointed in some of our politicians in the world that are getting tested as asymptomatic people. It doesn't make sense, and it's not good PR for what we're trying to do in public health. But the more testing we can do, the better, because then we can follow up with everybody. We can figure out who else they've been in contact with. We can try to determine where they may have been infected. And we have a whole team working on that. In fact, we have taken some of the medical students out of University of Kansas, and they are not allowed to see patients right now in the hospital or in clinics. So they are helping us do contact tracing phone calls and follow-up of individuals that do have symptoms, to try to get more people tested and help people understand what quarantine means, what isolation means, and what they should be doing in terms of protecting themselves, protecting their families, protecting the public. Some of you may have heard that the University of Kansas School of Medicine decided to let about 50 of the fourth-year medical students graduate early. They'd already completed all their coursework and rotations, and I don't have the exact date. Some of you may have it, but I think that either has already happened or happens next week in terms of those students. And so they will be out across the state, possibly working in some of the places where you all work. I think the idea is to get them to underserved communities, like rural communities and some of our urban communities. And so we're going to be recruiting some here in the public health world in Kansas City, because we can really use them. You can imagine that as you start to get cases and you get into 200, 300, 400 positive cases, each of those people might have 5 or 10 or sometimes even 20 contacts that they had just prior to symptom development and in the first few days of symptom development. And we have to get all those people on the phone and get them all convinced that quarantine for 14 days is the right thing for them to do. So it's a ton of phone calls. And we're trying to do it all virtually. I'm up here in the operations center at the health department. Nobody else is here now, but we usually have 3 or 4 people sort of scattered around this big room. And then we'll have all these students on a Zoom call, just like we're doing now,
Right.
and trying to get help and resources.
Well, and I wanted to see if anyone had any questions on testing, because you really gave kind of a nice overview of obviously where we are and where we'd like to be. But does anyone have any specific questions on testing and or specific to your organization or your patient population? You guys are very quiet tonight, so please chime in.
Hey, Jen, it's Lauren.
Hi, Dr. Nye.
Hi. I was going to just add, because I know we probably have a lot of members that care for oncology or cancer patients on this. I do feel like, and I don't know the exact protocol off the top of my head, but we do seem to have a lower threshold in our cancer center at KU for testing. So if we have a patient on active treatment or with cancer and they just have a cough or a respiratory symptom, we're able to get testing a little easier, which I found for some of our patients who are in rural Kansas, their local hospitals don't have the same guidelines.
And I think that that's a good point. There's a couple questions. I'd like to go to Dr. Sinclair's questions that we have for him as well, in that, I think there's a lot of worry that maybe patients won't tell you that they had a fever or symptoms because they don't want to not get their treatment, or they don't want us to kind of keep them at the door. And I think, I'd like to hear, and then we'll catch this in the slides too, but I think this feeds nicely into that discussion about how are we making sure that patients are feeling comfortable being transparent. And Dr. Barr, from your vantage point too, it'd be good to hear, different strategies that folks are using. And is this a problem? Are patients doing that?
That's a great question. I think we feel like we're seeing that in a community setting around here. And those aren't necessarily cancer patients, but they, worry about what might happen to them if they show up positive, and how they'll be treated and how things will be perceived. And I'm sure that happens with some of our cancer patients as well. Mm-hmm. There's a question on here about what are we seeing for false negative rates. I don't know what others have seen, but the literature and science I've seen on that is that we have about a 20 to 30% false negative rate. So that means 20 to 30% of the time a person probably actually has the virus, but when we swab them, we don't get a positive test back. We think a lot of that may have to do with the technique that's being used to do these nasopharyngeal swabs. It requires you to get the swab all the way through somebody's nasal cavity to where you're touching the swab to the sort of back of their pharyngeal cavity, which is uncomfortable for people. Although with the drive-through stuff we've been doing here, we've seen people tolerate it pretty well when they're sitting in a car. Sometimes I wonder if people don't tolerate it better sitting in their own car than they would in a doctor's office with a bunch of white coats around and on a sterile exam table. But we think we got to keep working on that. We don't see many.
Do you want to chime in on it?
Yeah. Somebody else want to comment on something?
Oh, you're on mute. Christian's on mute. There you go.
Oh, I don't have anything to add on that.
Oh, okay. I didn't know if you were seeing patients like not, sharing that they have a fever or they've been around. Okay, that's good. Because that's been in a lot of the webinars that I've been watching on cancer and COVID, really talking about how patients are doing that because they don't want to miss their treatments, which we can all understand. That would be, pretty stressful when that's where you are in your cancer care trajectory. So I think that feeds kind of nicely into this next section, like kind of going through the case questions. When we do see a patient who's positive on these testing protocols, which are the symptoms that are really going to take them into a hospitalization? Like, at what point are they triaged? Okay, you guys can go home, but you guys need to be hospitalized. And I think this is a really important part that we can be educating our patients and our care teams on, that level of triage as well.
Yeah, and we've seen that hypoxia, like I mentioned earlier, is a big piece of this. And we also have seen that we may have to shift our standards a little bit in some cases. With that long-term care facility I mentioned earlier, we had them trying to sometimes transfer more than a dozen patients to an emergency room in one day.
Right.
And maybe overreacting to a pulse oximetry level of 90 or 95, and somebody who might have some underlying COPD anyway. But people that get to 88, or 89 on their pulse oximetry are the ones that are getting admitted and needing to be on oxygen, and sometimes needing to, as they decline, needing to be on ventilators. And
Right.
I've seen some studies that the average length of stay with people who were COVID positive when they get hospitalized can be up to 22 days.
Mm-hmm.
So it's really the respiratory symptoms. There are some reports now coming out about cardiac symptoms and some sort of cardiac effects that can occur with the virus. And so that will be something we have to watch. I think those are probably real, and that the virus in some patients can cause, and we don't know if it's going to be transient like we've seen over the years with some other viruses. But if the viruses cause a cardiomyopathy of some kind, that's going to need treatment too. And if you get both that plus pulmonary issues, right, you can understand why that can be real significant. So, and as many of you know, right, we do see cardiac issues with cancer survivors. So we've got to be really diligent in looking for those things and monitoring for those things. But I do feel like, at least right now, we've got plenty of capacity in our state to do that.
And what about if a patient's at home, obviously they're taking their temperature, but what if they have their own little pulse ox at home and that drops? Should that be a reason that we would encourage them to call us as well as a fever?
Yeah, I mean, I think calling your provider is something we want to encourage people to do for any of these symptoms. And it doesn't hurt to do that earlier rather than later, and then continue to stay in touch with your providers. Most providers right now in the ambulatory world, and I imagine this is true even in the oncology world, are not as busy as we normally are, because at least in our ambulatory offices, because we've asked anything that's non-urgent or elective to not happen right now. And so I know certainly in my family medicine office, we've got a fair amount of capacity by phone to triage things. And I'm doing a bunch of phone visits and telemedicine visits. I'm sure Dr. Sinclair and others are too, which is a really exciting way for us to connect with our patients and provide support and guidance as this unfolds. But yeah, I mean, we don't want people sitting around with a pulse ox on their finger all the time, worrying and anxious, but interacting with their teams is an important thing to do. And I think most people would say we've got the capacity to support people on the phone right now, because maybe we aren't seeing as many people in the office.
And then this next slide kind of transitions into sort of predictions and how we can use data. This is from the University of Washington. Do you find this to be a reliable resource as well? So as we're looking at when our peak will hit, which is later this month around the 19th, the nice thing, like you talked about, kind of the curve seems to be flattening a bit. So we don't have that prediction now of not having enough beds or vents, but do you feel this is a pretty realistic resource for folks to use?
Yeah, I mean, I would say if people are digging into this type of stuff, trying to look at some of the modeling of the pandemic, this is from the University of Washington. There's also models that have been developed over at Washington University in St. Louis that some people like. There's also some out of University of Pennsylvania. So you can Google some of these things and find different models, and the different models have slightly different assumptions, right? So this model looks at things like whether you have a shelter in place order, whether your schools are closed, whether non-essential businesses are closed. And those assumptions then relate to what kind of curve you get. You can see that the margin of error is pretty massive in this mortality curve. But we're expected to, if we continue doing what we're doing, and I think the assumption in this one is that we would continue it through the whole month of May, we would end up with about 275 deaths in the state of Kansas.
Right.
but I would say look for multiple things. You know, keep looking for things that get put out by, you know, respected scientists rather than journalists. It's the same thing we all do all the time, I think, in healthcare, where we're looking for the best evidence, and it requires multiple sources to sort of weed through to come to the best conclusions you can. And unfortunately, it makes us all nervous with this, right? Because we might end up changing our minds. But we are hopeful that we are on a path to keep things from becoming a complete crisis here. The modeling for Missouri does not look as good. And,
No, it doesn't.
And we may end up, if we end up with a shortage of hospital beds, say in Missouri, with a lot of spillover into our state, certainly in the metro area, but possibly into other areas where some of the rest of you work. I mean, it wouldn't surprise me if we end up at the situation where we're having to rely on hospital beds in places like Wichita for spillover from the state of Missouri if things go the way they could go.
So that will definitely impact them. And I think that, you know, as we think about our cancer population, both those patients who are being treated and then looking at our survivors, there are some subsets of populations that from the experience both in China and in Italy, we're seeing a worse outcome. And you know, kind of transitioning into that, because we only have about 15 minutes left. Dr. Sinclair, do you want to chime in on any of these new reports that have come out, really highlighting, you know, because of what was described earlier, cancer patients are immunosuppressed. A lot of them are on things that are definitely exacerbating that in regards to inflammation. Any other kind of risk buckets that you've seen, or Dr. Nye, that you guys have seen that you'd like to bring up as we talk about patients with cancer?
It's one of the most common questions that we're getting from patients. They're asking us, am I immunocompromised? Am I immunosuppressed? Is my immune system not as efficient? And I think trying to address those questions early and often can help reduce a lot of the anxiety that comes along with this, because there is a lot of worry going on, and some of the worry can lead to productive action, but a lot of the worry can just get people into cycles. So for the oncologists on there, those who are working with cancer patients, really keeping basically, I try to bring that up in every conversation. One of my prompts is, with all the news about coronavirus, what questions do you have regarding your personal health and coronavirus? Because some people say, oh, I know, I've heard about coronavirus, but then they're asking questions about their own health, and I think that's important to bring up.
Well, and how do you guys address the fact that, you know, some symptoms of their treatment, whether it's fever, whether it's GI symptoms, I mean, some of those are overlapping. So do you have sort of a differential that you guys are going through as you're thinking about that? Or is that something where it requires a deeper dive?
Yeah, as a palliative care specialist, we definitely hear about a lot of symptoms as one of our leading ways that we're working with patients. And so I think this is more than ever a time for good teamwork and even over communication. So we've been trying to partner with our oncology colleagues as we are hearing symptoms come into our palliative care team to really differentiate, is this a coronavirus related situation? Is this related to their treatment? Is it related to cancer progression? And making sure that we're not so focused on coronavirus that we're ignoring some of the bread and butter things that happen for cancers when they're for cancer patients when they're undergoing treatment.
Well, we're still living like day to day, and that's the hard part, is that, you know, our patients are isolated at home. This is an initiative, obviously, that the University of Kansas Cancer Center has put out. And I think that as you're thinking about cancer patients being isolated at home, are you recommending, or because I've read some forums where they're actually suggesting that cancer patients stay isolated within their isolation at home. So like, no one comes into my space here because I'm undergoing cancer treatment, especially if they're coming in and out of the house. And how have you addressed that with your patients, especially some of yours being so, so advanced in their disease in some cases?
Yeah, so I think that's a great question, and we really take it as an individual risk assessment. We have patients who their other housemates, whether family or friends, they have essential jobs, and their relatives in their house are going out and interacting with large numbers of the public. We have other patients who they've been homebound for the last 6 months regardless, outside of any coronavirus, and so they've already been pretty socially isolated, and so their interactions are much less. So really take it kind of on a case-by-case basis. In addition to the risk from outside, also what is the patient's current, white blood count, what's their current cancer treatment regimen, and try and put that together to say what feels best for them. I think it's also important to remember that social interaction can be really good medicine too. We want to reduce that risk, but we really have to be careful on so much social isolation, even within a household, can really cause a lot of mental health issues that maybe put people in jeopardy long term without actually giving them much more benefit of risk reduction.
Yeah, absolutely. And using our technology, which we'll hear about from Dr. Wright momentarily, I think is also a good use, but a lot of our patients are having challenges with that. So I think as we think about these precautions, we talked about kind of the new things that came out about masks this week from the CDC. And I think building on to Dr. Greiner's point, the mask actually, as I've tried to wear it around my house just to see if I can even tolerate it, it at least helps me be aware of how much I actually touch my face. Mm-hmm. So if nothing else, I think maybe it's a training tool so we don't touch our face so much, because that is something that's so unconscious that we do on a regular basis. Do you also, you gave an example here, which I think is really nice. Can you kind of go through this and talk about kind of that technology piece and then your pathway for how you've adjusted dealing with patients potentially in this, high risk situation?
I think it's really important to recognize that this rapid skilling of our healthcare workforce in a technology that not everyone's familiar with, that's very stressful. And you'll have different members on your team who feel very comfortable and those who feel very intimidated by the new tech that they're going to have to learn. The important thing to realize is that once you master the tech, a lot of the other stuff falls away. And when you see your patient that you know on video, you instantly get that connection back. And once you get that happening with a few return patients, you realize, oh, I can still be very human and make a very good person-to-person connection, even with someone I've never met before. It's a little bit awkward at first, but it really starts to come together. So if you can work with your team to get over that intimidation of tech and get that settled, a lot of the rest kind of comes pretty naturally.
And you also highlight here, obviously teamwork makes the dream work, but the enlisting of the family. So what we need is then the team for the patient too. So we're encouraging really that two-pronged approach. Like, here's how we onboard the patient, but here's how we're onboarding the care team. And there's a lot of similarities you just highlighted, but what are some tactics you're using to sort of empower your patients who, to engage their family or their home care team?
So I think it starts with framing what the challenge is. And if anyone starts with a challenge and says, why can't it do this? You're probably not going to find an answer. But if you start off with, I wonder if it could, or I wonder how I could, then you're probably going to be more likely to have a wide range of answers and wide range of ideas. And so even when thinking about the exam, to say, I can't lay hands on the patient, therefore I cannot do X, Y, or Z. Instead say, hey, I have a camera, I have my visual, and I have a pair of hands there. So we've even replicated an abdominal exam. I've been able to tell by how the feedback from a family member on light pressing of the stomach, if that was a really, really firm abdomen or if it was a soft abdomen. For a patient, we were really concerned about a severe constipation and possible even obstruction. And the abdomen was very soft. So we really started from a standpoint of what can we do with this tech? And I think that helps you see all the possibilities.
Absolutely. That's a great example. And I think that as you're thinking about that fear and anxiety that our patients have, and these risks, when you are thinking about strategies and empowering your patients, you put together kind of a nice list here. Are there kind of things you'd like to go over and really talking about that patient engagement piece?
I think it's important to have a script for the key questions you want to ask. And the ones that is really surprising us in the palliative care space is, for our cancer patient population, is, do you have plans if someone in your household gets sick? Either you, and what would be the plans if you got sick as a patient, or your main caregiver or someone else? Can you self-isolate in the household and quarantine if it's needed? do you have another household you can go to or that other caregiver can go to? And really identifying who are patients who actually don't have an in-house caregiver. They're very vulnerable. And so we're trying to work with them to come up with plans. But I think having a checklist of a couple of key questions that you can ask every patient to make sure you're not missing something like their lack of food, lack of housing, lack of meds, lack of a caregiver.
That's great. And Carol Bush is asking kind of, does anyone have that sort of prepper checklist? And so we will query around and see if we can either find one or quickly pull that together, because that's a great idea to sort of send out and empower our patients with as well. Do you have a checklist that you actually give to the patient, Dr. Sinclair, or is it more of a verbal checklist you guys are going through?
Our coordinators are actually, when they're scheduling the visit, are testing it out with them and showing them. And what's really great is there's a great sort of sense of accomplishment and surprise and wonder and gratefulness from patients and families when they're like, oh, this works. I can see you and I don't have to put my health in jeopardy, and we can still get our healthcare delivered to us. It's really pretty amazing when it starts to click. And we've had a lot more positive feedback, even as you work through the technical difficulties.
That's a great point. So quick question for you guys. Are you all using telehealth services in your practice right now? And we will go ahead and see if we can pull this next question. Maybe not. Let's see. There we go. Hopefully you guys can see that. I think I'm improving my polling ability. So yeah, it looks like a lot of you are. So about 88% of you guys are using telehealth, and I think that we are across the continuum on that. And so then the good or the bad is we're all getting better. Within a 18-month time frame has now been converted to what, like a week or 2 weeks, Dr. Wright? So I know we haven't left you with a lot of time, but I'd love for you just to dive in real quick, and then we'll talk quickly about what we have coming up in your.
I'll do this as quickly as possible. I want to thank Dr. Christensen. This wasn't going to be a part of my talk, but I just want to re-emphasize what he said in terms of if you've already established those provider-patient relationships, they translate very easily to telehealth. And once you're feeling comfortable with the technology, it really isn't a chore to develop relationships with new patients over telehealth. Your skills translate once you get used to the technology. I'm going to keep this brief today. I would have pulled that question and said, how long have you been doing telehealth? Did we start yesterday? And it's okay if you have. Right now, we're just going to show you a few things in terms of resources and how to stay on top. There's so much coming out about telehealth, so much information, and things are changing very rapidly. And oftentimes the guidance that we get for changes in billing and what we're allowed to bill and where we're allowed to bill actually come in response to federal or state legislative actions. And oftentimes that right now that's, in response to an executive order. So it's good to follow the news and see what's going on legislatively, but then that trickles down. So on a federal level, and we're thinking more like, Centers for Medicare, Medicaid, CMS, they're going to keep us up to date on what they're allowing and the doors they've opened to telehealth. Of course, the Department for Health and Human Services, the DEA, they're all jumping in. The Office for Civil Rights made some statements to assist us in managing HIPAA with so many people coming online. So we're going to look at some of those resources for updates and guidance for telehealth. I also want to mention that's not listed here. We do have the National Telehealth Resource Centers, and they're going to keep things up to date on their websites. On a state level, we're seeing information come almost on a daily basis in terms of what we can do and the doors that have been opened for telehealth. So we're going to look to KDHE, KDADS, of course, the KMAP general bulletins. And notice a lot of those resources are going back to our Medicare, Medicaid. We're not seeing a lot of telehealth information being published in terms of billing from our private payers. Sometimes we might feel a little bit, like there's some resistance there. I don't know that they're trying necessarily to be obstinate. What we have to keep in mind there is that our payers have different employer groups. So Blue Cross Blue Shield for the state of Kansas might look a lot different than Blue Cross Blue Shield if they are, purchased by an employer group that's a nonprofit and it's a small nonprofit. So they're not going to make really global or large reaching statements because what they may offer one group may differ from what they offer another just based on, the financing there. So we need to contact those private payers individually to kind of see what's going on in the world of telehealth. And again, when we look at, our licensing boards, they're going to give us some information. This next slide here really kind of represents our core fundamentals when we look at setting up telehealth. Oftentimes we get so focused on the clinical, we forget that those other cores are there, the administrative and technology. Usually we're giving at a minimum 9 months to set up a sustainable telehealth program. And most of us had to set up telehealth yesterday, right? Without that core setup. And really what I'd like you to think about as you're setting up your telehealth is we have the technology to reach our patients. It's a safe thing to do. We can do it. But any telehealth program that is new, that is set up in response to this crisis, or if we've really grown a telehealth program in response to the crisis, I want you to think of that as almost like setting up a medical tent. And you're not the only one setting up a medical tent. We're doing that across the nation. It's meant to be temporary, and a lot of these exemptions and waivers at the federal level, they're designed to expire. So as we go into telehealth, we need to do the best we can with the resources we have. We don't need to go buy a $10,000 robot to start our telehealth program. Let's use what we have and really kind of triage our administrative, clinical, and technology needs so that we can meet the needs of our patients. And right now, thank goodness, we can do that in their home, which really has not been paid in many instances before. Again, communicating with your partners and seeing what they're doing can be very helpful. We'll do longer term planning as we go forward. And really quickly, I'll share with you some of our resources. There's a link here to our website. We have pushed out several brief videos called Telehealth Bites to help providers kind of acclimate to telehealth. And more importantly, in a very short amount of time, we have set up a telehealth echo that launches tomorrow. That will be every Thursday at noon in April, noon to 1, and we'll be addressing the needs of providers and organizations as we step into this telehealth space in a real kind of rapid response manner.
And Dr. Wright, I think the important part about this telehealth deep dive is really going to help people with all the things that are going through their minds right now. So, we'll touch these little nuggets, kind of like you just highlighted and summarized for this echo, but we really encourage folks to take that deeper dive, because this is something that now that we've accelerated the use of telehealth, it's very likely that a lot of this is going to stay beyond, just this crisis. So it's really an important thing to get our arms wrapped around. And I think this is a great opportunity to do that.
Absolutely.
So, you bet. And in light of time, this is also another billing and coding coming up specific just to cancer. So please feel free to look at those resources from the Association of Community Cancer Centers, which will also be in the toolbox. We were going to talk a little bit about self-care, but we're going to push that to the next echo. So we'll dive a little more into how are we looking at HCP self-care and really hone in on how are we taking care of our team, how are we assessing those needs, and so forth, because we know that's vitally important during any type of crisis situation to prevent both compassion fatigue and burnout. So we're going to summarize and open up, once again, your 51 NI, and we'll stop sharing and we'll stay on for just a few minutes for any other follow-up questions, because I know we didn't get to as many questions as we'd like to normally do, and I don't want to leave anyone's, burning questions hanging. So in this last, probably minute, because we're already over by a couple, any other questions, any other things for our experts before we end? And of course, you can always reach back out to us and we will answer your questions as well.
Jen, Dr. Sinclair left some messages in the chat that we can summarize and put in the toolbox.
Very good. Thank you. And that toolbox is really meant for you guys to help us put those tools together that you need as well. So as you've heard things tonight, if you want to put them in the chat box, what are topics you want to make sure we cover? We want to bring in administrative leaders. Who else would you like to hear from to really help answer any questions that you have? So don't be shy. I know most of you are not shy. So put it in the chat box, call us, email us. And I love Carol Bush for saying, don't reinvent the wheel. It's absolutely right. Our circle of care and our circle, this community of practice that we're building is meant to be that collaborative network. All right. Anyone else before we end? And I'm sorry, we'll be a little bit more traditional echo, I hope, next time. We wanted to cover a lot with Dr. Greiner being on tonight about the nuts and bolts, because that really does help guide us on how we care for our special populations like cancer patients and cancer survivors. So we want to thank you all so much for joining in. We will see you again next Wednesday. Here you are with your code to get your credits. We'll see you next Wednesday from 4:30 to 5:30, and let us know any other topics that you'd like. And you guys all stay safe and stay well. And thank you to our experts, Dr. Sinclair and Dr. Ryder still on, as well as our ECHO team, and to all of you. All right, take care. Have a good night.